Thank you for the opportunity to participate in Gastrointestinal Endoscopy's author interview series. My name is Megan Adams, and I am a third-year fellow at the University of Michigan in the Division of Gastroenterology. Today, I will offer some additional insight into our study entitled Predicting the Likelihood of a Persistent Bile Duct Stone in Patients with Suspected Choledocholithiasis, Accuracy of Existing Guidelines, and the Impact of Laboratory Trends. Choledocholithiasis is a common clinical problem. ERCP is highly effective in relieving biliary obstruction, but carries an increased risk of complications, including post-ERCP pancreatitis and post-sphincterotomy bleeding, as well as perforation, infection, and anesthesia-related adverse events. Therefore, when the diagnosis of choledocholithiasis is in question, other modalities such as endoscopic ultrasound and magnetic resonance cholangiopancreatography represent highly accurate, lower-risk alternatives for initial evaluation. Risk stratification strategies are important in helping restrict ERCP to patients with the highest probability of choledocholithiasis, in whom the risk-benefit ratio is most favorable. In 2010, the American Society for Gastrointestinal Endoscopy published guidelines to help practitioners risk stratify patients with suspected choledocholithiasis into low probability, intermediate probability, and high probability groups. The guidelines define very strong, and moderate clinical predictors of choledocholithiasis based on clinical presentation, laboratory, and ultrasound findings. According to the guidelines, the presence of any very strong predictor or both strong predictors indicate a high probability of choledocholithiasis for which an ERCP is recommended. High probability is specifically defined in the guidelines as a greater than 50% likelihood of choledocholithiasis. Patients classified as intermediate probability are best suited for a less invasive initial test, such as EUS, MRCP, or intraoperative cholangiography. The ASGE guidelines present a straightforward algorithm for the management of this common clinical scenario. However, their accuracy in predicting ongoing choledocholithiasis has not been widely validated. Furthermore, the guidelines do not provide direction regarding whether patients should be re-stratified when there has been an evolution of laboratory trends prior to their initial diagnostic study. Some clinicians believe that a comparison of liver function tests over time is highly informative, with decreasing values suggesting spontaneous stone passage and prompting a less invasive initial intervention. Others proceed with ERCP even in the setting of downtrending LFTs, suspecting a ball valve effect. This ambiguity in the guidelines was the driving force behind our study. This was a single-center, retrospective cohort study of patients hospitalized at the University of Michigan Medical Center with suspected choledocholithiasis between 2007 and 2012. Our study had two primary aims. First, to assess the accuracy of the current guidelines for predicting ongoing choledocholithiasis, and second, to determine whether incorporation of laboratory trends would improve overall guideline accuracy. To identify cases of suspected choledocholithiasis, we reviewed all EUS, MRCP, and ERCP cases in our institution's endoscopic and radiology reporting databases. Medical records of potential cases were then reviewed in detail to evaluate for the presence of pre-specified eligibility criteria. Subjects were excluded if they had a condition that might confound interpretation of liver biochemical markers or ultrasound findings and thereby might affect performance of the guidelines. 498 patients met inclusion criteria. Of these, 35.9% met ASGE high probability criteria at the time of presentation. Only 55.3% of these high probability patients had a stone or sludge on subsequent MRCP, EUS, or ERCP. The remainder had a negative evaluation. Of those cases not meeting high probability criteria at presentation, 65.2% had no sludge or stone on subsequent diagnostic study, while 34.8% had a stone or sludge present. Overall, as applied to our cohort, the guidelines had an accuracy of 62.1%, a sensitivity of 47.4%, and a specificity of 73%. Multivariable logistic regression revealed that only visualization of a stone on ultrasound with an odds ratio of 5.47 had a strong independent association with the presence of a stone on ERCP, EUS, or MRCP. bilirubin greater than 4 milligrams per deciliter, and bilirubin between 1.8 and 4 milligrams per deciliter were more weakly associated, with odds ratios of 2.03 and 1.97 respectively. Contrary to our hypothesis, the accuracy of the guidelines was unchanged when incorporating the second set of liver chemistries obtained after admission but before the initial diagnostic test. This suggests that laboratory trends do not improve performance of the guidelines. There are a number of important limitations to our study. First, due to application of strict exclusion criteria, our results are best generalized to healthy, non-cirrhotic patients with no concurrent biliary conditions. Second, there was significant variation in timing between the first and subsequent set of laboratory parameters, which may have influenced the results. Third, we were unable to evaluate the impact of clinical symptoms on the likelihood of choledocholithiasis due to the retrospective nature of the study. Given the morbidity and economic costs associated with ERCP-related adverse events, the increased availability of EUS and MRCP, and the growing movement toward purely therapeutic ERCP, we submit that a greater than 50% likelihood threshold is too lenient to justify exposing a patient to the increased risks and costs of ERCP. In our view, striving toward a higher likelihood threshold is warranted. To this end, further research focusing on more accurate and reliable risk stratification modalities is justified. This may include an early EUS strategy in which all patients, with the exception of patients with a bile duct stone on ultrasound or patients with ascending cholangitis, have an EUS first and only proceed to ERCP if positive. Additional research is necessary to further evaluate this strategy. Other options under study include use of novel predictive modeling techniques, such as artificial neural networks and other machine learning techniques. In conclusion, current guidelines demonstrated suboptimal diagnostic accuracy when applied to our cohort, likely resulting in overutilization of ERCP. Incorporation of biochemical evolution does not improve their diagnostic accuracy. In order to minimize ERCP-related complications and deliver the highest value care to our patients, additional research focusing on alternative diagnostic strategies is warranted. On behalf of my co-authors, I would like to thank the editors of Gastrointestinal Endoscopy for inviting us to participate in the author interview series. Thank you.